It's a privilege for me to be here today. I'd almost like to talk without slides because what I have to say could be summed up very briefly. Don't believe everything you hear or read. It could kill you. I have no financial disclosures, fortunately or unfortunately. The goal for me is to emphasize risk factors and early diagnosis. Early diagnosis of melanoma is tantamount to cure. So early diagnosis is the goal. An ugly or unusual mole, think melanoma. And that's out on the street, on the beach, in the locker room, think melanoma. Now, the key to diagnosis of curable tumors, and that's examination of the total mucocutaneous surface. Melanoma can occur anywhere on the mucocutaneous surface: nails, scalp, anus, genitalia, palms, soles. Most tumors occur on relatively sun-protected sites. No examination of the skin, no diagnosis of a skin tumor. That's it in a nutshell. Do physicians examine the skin? Well, this is a health survey in the United States, 1992. Patients said ever had a skin examination by a doctor? Only 20% in 92, 2000, 14%. A recent skin examination, even worse, about 10%. So there's the crux to the problem. The skin examination is part of the physical examination. It's generally not being done. Now, Farrah Fawcett died of metastatic squamous cell cancer in the anal area. Physicians rarely examine the anus or genitalia, sites of not only squamous cell cancer, but also melanoma. Early diagnosis equals cure. Who discovers melanoma? The physicians the solution or part of the problem? Patients, half the time. Family members, another 20%. So about 70% of the melanomas are diagnosed by family members or patients themselves. Unfortunately, physician-diagnosed melanomas are much more curable than patient-diagnosed melanomas. They're much more advanced when patients diagnose them or patients' families diagnose them than when physicians diagnose them. So this is the message. No diagnosis of a skin tumor if you don't examine the skin. I think patients need to push for a complete examination of all the sites. Now, are there downside risks to public messages? I grew up in the 50s, actually in the 40s, and I diagnosed my own father's melanoma. He died 4 years later. It was a delayed diagnosis because the general docs who looked at it didn't know what they were looking at. And that was back in '73. So it ain't what we don't know that's a problem, it's what we know that ain't so. Warning signs in those days and misconceptions 50 years ago, the warning signs applicable to skin: sores that don't heal, bleeding or oozing in a mole, painful mole. These messages guaranteed delayed diagnosis. That was part of the American Cancer Society signs of cancer referable to skin. Also, the prevailing notion for people in the room who remember, taking a mole off causes cancer. So that didn't help things either. Tumor thickness, the most important independent predictor of survival. Only for me to say that if your tumor is real thin, 10-year survival approaches 100%. If it's thick, 3.5 millimeters or more, it's a grim situation. These are the melanomas we saw in the early 70s. Not bleeding, not painful, doesn't hurt. Why go to the doctor? So these are picked up incidentally. Looks kind of strange, doesn't it? Can you believe it? Can we get the lights turned down at all? These slides need lights turned down in the room. Otherwise, we won't be able to see. Patient waited for pain, oozing, and bleeding. Delayed diagnosis, thick tumor, death in more than 2/3 of cases when it's 4 millimeters or thicker. The ABCDs of melanoma, this is another public message, I think, with potential pitfalls. Remember, A is asymmetry. One half doesn't match the other. Border irregularity. Color, lots of different colors. Diameter, size of a pencil eraser, or larger. Well, some of us have been arguing to get rid of this. These are morphologic issues. The pictures are good, although the tumors are more advanced than we'd like. How can I advance the slide? It's not advancing. Nodular melanoma comprises 10 to 30% of melanomas. The color is often uniform black or blue-black or red. Margin often smooth and regular, and the diameter is less than 6 millimeters initially. And this is one of the most deadly tumors. Now remember, 2% of melanomas in adults are non-pigmented. They're pink or red. And in pediatric situation, about half of all pediatric melanomas are amelanotic, red papules or nodules. So the standard of care in pediatric melanoma, the standard of care is to miss the diagnosis because nobody thinks of it. Right now, about 20 to 30% of melanomas in Australia, Italy, and the United States are 6 millimeters or less. Tumor diameter increases with age. Tumor diameter and thickness are directly proportionate. You see the thin, smaller tumors in younger people. The thick, bigger tumors in older people. These lesions grow with time. So if you're only focusing on older people, and older men is where we're seeing most of the mortality now, you're going to guarantee advanced tumors. This is the warning sign of change, and in that, it's a changing mole or a new mole. They mention change, but not new. So about 30% of melanomas present as a new mole. The rest, a mole that's there, and the mole changes. I'd love to advance the slide. How can I do it by hand? Can somebody sit by the computer, please, and help me advance the slides? And this is the new ABCDEs of melanoma, where all the features I mentioned. Melanoma is not a word, it's a paragraph. There's no single cause for this tumor. It's a very heterogeneous disease. If you think all melanomas are caused by the sun, you're going to get screwed. You're going to die because you'll have an advanced tumor. Only about 10% of melanomas are clearly caused by the sun, and that's the lentigo malignant type. The rest is conjecture. So what are the potential precursor moles and risk factors for developing melanoma of the skin? You'll tell me, Howard, you'll come up and hit me when I'm 30 minutes. I'll just stop because there's no way I can do all of this. So we're going to talk about the precursor moles. This is a congenital mole. 1% of newborns have a congenital mole. There's a melanoma sitting in it. This should not occur by chance. It's a potential precursor. We'll talk about that. Pre-existing mole at the site of melanoma. Based on patient history, it's roughly 60% range anywhere from 20 to 90%. Everybody's got moles. The question is, which moles are the bad actors? And that's what we're going to try to talk about. Advance it, please. Thanks. I'm not going to cover all this, but the top you'll see melanocytic neoplasm, nothing to do with ultraviolet, dysplastic nevi, congenital nevi, and an assortment of others. Here, ultraviolet-induced lentigo malignant comes from sun-induced freckles, which 20% of white people have. You can get melanoma in the brain arising from leptomeningeal melanocytosis, a proliferation of melanocytes on the lining of the brain, especially with giant congenital nevi. Melanoma can arise on skin where there's nothing, mucous membranes, middle ear, intestine, gallbladder. Melanoma can arise almost anywhere. So what are the dominant risk factors? I like to arrange the risk factors according to importance. So I'm going to skip this disease. It's a rare disease that can't repair damage to ultraviolet radiation, sunlight. Xeroderma pigmentosum, about 5% of those kids will get melanoma by age 20. Most of them don't live very long. Dysplastic melanocytic nevi, the most important risk factor and potential precursor of melanoma. Now, in the familial melanoma setting, where 2 or more members in a kindred have melanoma, if the patient has had a prior melanoma in this setting, 500-fold increased risk. no prior melanoma, over 100-fold risk still. Even a single dysplastic nevus with no family or personal history of melanoma, at least a 7-fold risk for melanoma. You can tell somebody at risk just looking at their moles. Prominent numbers of moles, big moles, just the number and size. A number to remember, a dozen moles the size of a lentil bean, 40-fold increased risk. If you're white versus African black, 15 to 20-fold increased risk. But no ethnicity, no one is immune from melanoma. If you've had a prior melanoma, it's a 9-fold risk for another one. You need to be followed for life. And if you've got dysplastic nevi, your risk goes way up. A melanoma in a first-degree blood relative, about an 8-fold increased risk. Now the low-risk traits. Immune suppression, about a 3 to 4-fold increased risk. Dense freckles, 3-fold risk, independent risk factor. And you multiply any other risk factor by that if you have other risk factors. Sun sensitivity, poor tanning ability, about a 3-fold risk. Red hair, 2 to 3-fold risk. Blonde hair, green or blue eyes, controversial. Frequent sunburns in childhood or later. Anything less than a 3-fold risk, I worry about confounders. And the biggest confounder is recall in these epidemiologic studies. Excessive sun exposure, lifetime, occupational or recreational, controversial. And that's what is our national strategy to prevent melanoma. That is our national strategy, and it's going to cause problems. So let's talk about typical moles and high-risk moles, but I almost feel like going to the end of the talk and talk about the important issue. I talked about freckles, the pathology of freckles, that's lentigo maligna, which can kill you if you let it go. Melanomas, I'm going to let Dr. Vijay Reddy talk about pathology. Current tumor progression model for melanoma of the skin provides a window of opportunity for early diagnosis and cure in a pre-metastatic phase of development. So this is an early melanoma. I happened to be a secretary who used to dictate my letters when we could afford dictation of letters. We can't anymore. So this was a small lesion, less than 6 millimeters. It's a thin tumor in radial growth phase. That means the melanoma is confined to the epidermis or a few cells dipping down. It's a curable tumor. This is nodular melanoma in vertical growth phase with an aggregation of tumor in the dermis with a lot of mitosis, bigger than anything in the epidermis. These are all malignant cells, and that has the potential for metastasis. Radial growth phase, no potential as long as there's no regression. So the goal is to reduce mortality. Total skin exam should be offered to every new patient, diagnose melanoma in an early phase of progression, recognize people at high risk, and keep them under surveillance for early detection. Dysplastic nevi account for about 30 to 40% of melanomas, rare and darkly pigmented ethnicities. Congenital nevi, 8 to 15% of melanomas arise in the congenital nevus. Lentigo maligna accounts for 7 to 10%. That's sun-induced. Nevi on these areas, palm soles, nails, mucosal, 5% of melanomas occur in these sites, 50% in blacks. And de novo, that means there's no lesion there, 30 to 40% of melanomas, just on normal skin, mucous membranes, or nail bed. Or it may not be detected by the patient because this history is from patients. Now, these are prominent mole patterns. You can walk in the room and see somebody, he's got at least a 40-fold increased melanoma risk just by a glance at the skin, if you can tell seborrheic keratoses from nevi. This man already had 2 melanomas. About 1 to 4% of white adults have atypical nevi, at least one. And this many, it's probably less than 1 in 1,000. This is a significant risk factor, and each of those lesions could be precursors. These are ugly-looking moles. They can look like fried eggs, or they can look just like haphazard pigmentation, almost like mini melanomas. And the ABCDs of melanomas fit dysplastic nevi. That's where there's a problem with the ABCDs, one of the problems. We advance, please. Now, the pathology of this, I don't know if Vijay is going to talk about dysplastic nevi. It's a scrum of melanocytes that are irregular, not malignant, not benign, in between. Everybody knows what a scrum is, I guess. Advance, please. This is a scrum. The girls at Williams, where my kids attended, these were rough, tough bunch of kids. This is a scrum of melanocytes, and they're variably atypical, not malignant. Can I have it advance, please? Dysplastic nevi were first recognized in familial melanoma setting, which only accounts for 10% of melanomas. 90% are non-familial. Patients were photographed and followed. And go back one, back. Okay, look down here, advance one. And there's a mini melanoma popping up. Now, melanoma risk in patients with dysplastic nevi in the familial melanoma setting was a 150-fold risk if patients had not had melanoma, just came from those families, and had atypical nevi, up to 500-fold risk if the patient had had melanoma. It's 500-fold risk for another one. And patients, only those with dysplastic nevi, develop melanoma. This is dysplastic nevi in the sporadic melanoma setting. This was a lawyer that had one melanoma, loaded with atypical moles, called me up a year after I was following him. One of his moles changed. We photographed people to follow them. And this was a mini melanoma, curable. This is the way we like to get them. Upwards, our study initially suggested 22% of melanomas arose in dysplastic nevi. We were ridiculed because it was the non-familial setting. Now it's upwards 30 to 40% when other people have done the same studies. So 30 to 40% of melanomas arise in dysplastic nevi outside the familial melanoma setting. It's like polyps and colon cancer. This is a famous professor who was a friend of mine in the 70s. We used to party together. I never saw him undressed except out on the beach one day. I said, you got to get looked at. And he had lots of atypical moles. Of course, he didn't come in. He's a doctor. He's immune to everything. He came in about 2 years later. One of his moles had darkened and then made a bump and then lost pigment around it. 2 of his kids had dysplastic nevi. So it's clearly familial. And this was a physician at MGH. This picture is in memoriam in the walk-in clinic. His fiancée, wife-to-be, also a doctor, was listening to a talk like this, ran home, got her, husband-to-be, brought him to us. He had a family history of melanoma. He was loaded with atypical moles. He should have known all about this, and he was dead in a year. 1.1 millimeter thickness. Now, photographic surveillance leads to detection of early melanomas that would have been missed otherwise. This is a technique that some of us are using. There's a template showing the poses. I'm not going to show you my own pictures or other people's on this, but this is the kind of setup I'm using. It's a Macintosh 27-inch. It's on a cart. It's on an islet. So the Macintosh goes flat, and we look at the whole body compared to the total body photos. So I sort of invented this setup, and it works. It takes about 45 minutes to do, 30 to 45 minutes. We compare every mole on the patient and the baseline, every anatomic site, looking for new moles or changing moles. And this is for high-risk people. Is such a high-risk person. He had lymphoma, family history of melanoma, no personal history of melanoma. Try to think which mole is new or which is changing. Impossible. Most doctors will choke when they see this, and I don't blame them. So this was a new mole we picked up, okay? I wouldn't have picked it up. And if you look at his baseline, it was not there. And here side by side, okay? It's a new mole. Does this look like melanoma? Raise your hands if you think this is melanoma. It's 2 millimeters. Certainly doesn't fit the ABCDs, does it? Yeah. And there are some features on dermatoscopy, surface microscopy. It's a 10x loop, drop of oil, bright light, looking at the pigment pattern. I'm not going to go over that right now. This was an early in situ or radial growth phase melanoma, curable melanoma. And he subsequently developed other melanomas on photographic surveillance. This is a patient, 47, family history, but no personal history of melanoma, lots of atypical moles. Look at this double mole here as a marker. This lesion we found had changed. Advance, please. Okay, you can see this doublet. And another, please. I mean, this is a little tricky, okay? This was the mole here, okay? Here, and that's covering the other. So this probably would have been missed on a cursory exam. Does this look like melanoma? 2 or 3 millimeters, but on dermoscopy, you see this radial streaming, blotches, loss of structure. These are all features of melanoma, gray haze. Just with a bright light, a loop, and a little oil. Red sky at night, sailor's delight. Red sky in the morning, sailor's warning. Remember I said 2 to 4% of melanomas in adult whites are red. And these screw everybody. Nobody thinks about it. So woman I'm following, because of the family history, loaded with atypical moles, no personal history, picked up this lesion. Nothing there, okay? This was a new lesion. And it was about 3 millimeters. I didn't really pay it too much attention because it looked so bland. Pretty bland looking. I think the doctors in the audience would agree, fairly bland. But what the tip-off was these red dots that we see under oil and 10x loop. That is not a typical mole. It's either melanoma, epithelioid cell tumor, or clear cell acanthoma. It's the only thing that could be. And it was a melanoma. Okay, DJ? Advance, please. Okay, this is an early melanoma. Would have missed it otherwise without using this kind of photography. White male with Parkinson's, loaded with atypical moles, no family or personal history of melanoma. Red plaque appearing in a mole. You see the red dots? That was the tip-off that it was amelanotic melanoma, which it was. Nevi in the scalp is a tip-off. The patient probably has dysplastic nevi. How much time do I have? About it. Wind it up, and I'm going to stop right now. Okay?